just give control to Alaric by making him co-host, so he can control
Yes.
this the mute.
Yes, sir. So good evening, everybody, and welcome to this MOA Masterclass 37th. And I hand it over to Dr. Ajit Shinde, the MOA President, to initiate the proceedings. Over to you, sir.
Thank you, Shyam. Good evening, friends. Greeting from Maharashtra Orthopaedic Association. I, Dr. Ajit Shinde, President of Maharashtra Orthopaedic Association, welcome all of you to MOA Masterclass series. Presently, we are discussing pediatric orthopedic, and today topic is case-based interactive series, Clubfoot through the ages. We have experienced stalwart Dr. Taral Nagda and Dr. Sandeep Patwardhan as a convener, and brilliant panel of pediatric orthopedic surgeons to discuss the topic. Dr. Alzik Arudis, Dr. Rujita Madam, Dr. Atul Bhaskar, Dr. Viraj Shingade, Dr. Samir Desai, and Ishani Shaha. Clubfoot is one of the common deformities we get to see in our OPDs. Though the Ponceti technique has revolutionized the treatment, many a times we see a neglected or relapsed cases in various age groups, and it can have a tremendous impact on child's social, educational, and even psychological environment. So our awareness amongst public regarding this easily curable entity is essential. So today we will discuss all such cases, and I am sure our brilliant faculty will walk through all of it. So without wasting much time, let's begin the session. Over to Dr. Rujita Madam and Arjit.
So good evening, everyone. And thank you very much, Dr. Shinde, for this wonderful opportunity to really bring to you a comprehensive package about clubfoot treatment. As all of you all are well aware that Ponceti has really changed the way clubfoot has been treated all over the world. But as far as India is concerned, we have to be something like a juggler. You have to be able to treat what comes in the urban setting, what comes in the rural setting, what comes early, what comes late. And of late, what has really started picking up is something which is known as antenatal consults. So we thought we'll take this like a story that when there is a lady who's pregnant and there's a lot of happiness, and then it's something like kuch kuch hota hai, and people are very happy, and then suddenly when one of the antenatal scan picks up CTEV, then bahut kuch ho jata hai, and that's where the pediatric orthopedic surgeon really comes into the picture. So to take us through a case and what should be the ideal antenatal counseling, we have Dr. Samir Desai from Pune, who I'll request to really take us through a detail and literature review. I'll request all the speakers to stick to time as soon as Samir's presentation starts. Over to you, Samir.
Yes. Thank you, madam. Good evening, everyone. And counseling in clubfoot is a very important part of practice of a pediatric orthopedic surgeon. So let us consider three case scenarios. The first case scenario is when the ultrasound report has been reported as normal, but now the report has come out to be clubfoot and the mother is 30 weeks pregnant. The second case scenario is the mother is 18 weeks pregnant and they come to us with a report of clubfoot. So what should be done? And the third case scenario is when an ultrasound report has showed an isolated clubfoot deformity, but after birth, other congenital anomalies were seen. So the points that I will be discussing are the incidence, the family history, ultrasound diagnosis, what are the pitfalls, what is the classification system that is used, role of genetic tests, role of amniocentesis, treatment outline and counseling tips, and finally motor milestones. So this is the first case. They did an ultrasound at 13 weeks, which showed a normal child and no clubfoot. When ultrasound was done at 23 weeks, the ultrasound was reported as left-sided clubfoot. And at 30 weeks, it was reported as bilateral clubfoot. Now parents were confused. So why was this happening? So let us see what are the problems in the diagnosis on ultrasound. So prenatal diagnosis of clubfoot has a false positive rate between 0% and 29%. And also if there are many cases where it has been diagnosed as clubfoot and it turns out to be negative. So the child did not have clubfoot. So always there is a chance either way. So optimal time to diagnose is between 14 to 16 weeks of gestation. This is because if you do ultrasound at a later date, there is a chance that it could be a positional clubfoot. Then the reasons for inaccuracies are sonographic technical factors, visibility at different gestational ages as already discussed, and dynamic factors. So 3D imaging may have a role in improving accuracy of diagnosis, and there is a 15 to 20% chance that diagnosis may change from moderate to severe and vice versa. And also it is important to remember that there is no relation of antenatal severity and severity grading after birth. So a lot of parents are concerned that on sonography it has been reported as severe clubfoot, and then later on it turns out to be a mild or a moderate clubfoot. So this has got no correlation. So remember that. The commonest classification that is used on ultrasound is when the angle formed between the tibia and the foot, when it is 0 to 80 degrees, it is classified as mild. When it is 80 to 100 degrees, it is classified as moderate. And when it is more than 100 degrees, it is classified as severe. So as an orthopedic surgeon, what are the things that you should look out for in the ultrasound report? So you could remember it as A, B, C, D. So A for arthrogryposis, look in the sonography report whether the sonologist has mentioned whether active movements are present or not, active fetal movements, limb movements. B for back, that is spine, whether any congenital spinal anomaly, spina bifida or any other spinal anomaly is mentioned, whether there are any cardiac defects or other congenital anomalies like cleft palate, whether any dysplasias have been mentioned on the sonography report, whether there are urogenital abnormalities, or also some intelligent sonologists will also mention the status of the tibia or tibia hemimelia. So this is a child who had trisomy 18 and which was easily diagnosed on ultrasound. So now let us look at the syndromes and the detection rate on ultrasound. So you can see that the detection rate varies right from 50% to 98%. So, and the easiest trisomy to diagnose is trisomy 18 and 13 because they have got lot of signs. So suppose if you have got a child who's already had a clubfoot, and what is the risk of the next child having clubfoot? So there is a 2.5% chance if it's a boy, and if a girl has a clubfoot, then there is a 6.5% chance that her next born sibling will be born with clubfoot. So if no parent is involved, then it is just a random occurrence, that is 1 in 1,000. But if parents have a clubfoot, then their baby chance of having a clubfoot is between 20 to 30%. What are the genes that have been described in families? And the common genes are Hox gene and P1TX1 transcriptional pathway. But we did a study in Pune, and unfortunately we were not able to find any gene. But yes, in India also some genes have been described. So now let us look at the second case scenario. So the mother is 18 weeks pregnant and the report has come as bilateral clubfoot. There is no family history, and the risk factor that is there is the mother is 35 years old. So what are the blood markers that are advised, and what is the role of amniocentesis? In the first trimester, what the gynecologists are usually doing are the pregnancy associated plasma protein, the free beta HCG, and the nuchal translucency measurement by ultrasound. So this is the actual photo of the report that was given to the parents. So you can see over here, so they have mentioned that there is very low risk, but still there is a risk. So considering the age of the mother, we decided to do amniocentesis. So what are the indications for amniocentesis? So the indications for amniocentesis are if there is a previous history of termination, if there is advanced maternal age that is more than 35 years, if there is history of consanguineous marriage, or if there are abnormal maternal serum screen results. So in this family, we did amniocentesis and the report turned out to be negative. So what is the current consensus about amniocentesis? Amniocentesis, people say that it should be done because abnormal karyotypes in about 6% is seen in about 6%, and subtle associated malformations are detectable only later in the pregnancy. But those arguing again say that this percent is fairly small, and if the deformity is isolated and no other structural anomalies are detected, then amniocentesis is not recommended. So ideally, amniocentesis is not recommended in a lady who is less than 35 years with normal blood markers. Because amniocentesis also has its own risk, miscarriages, injury, and there are reports where having amniocentesis early is associated with increased risk of unborn baby developing clubfoot. And the limitations are that congenital myopathy can be missed. Some neuromuscular conditions can also be missed. So amniocentesis is also not foolproof. So now let us look at the third case scenario. Ultrasound was done at 20 weeks, showed bilateral clubfoot, did not mention anything about limb movements. Blood markers were negative, but an amniocentesis was not performed. And the child had all these deformities. So then what should we do? How should we counsel? Fortunately, we had fairly good result in this child, but I have seen children with normal sonography reports and having amniotic band syndrome, another child with syndactyly absent toes, another child with tuft of hair on the back, or this child which turned out to be a syndrome later on. So there is always a chance that some syndrome or some condition may be diagnosed after birth. So we have to tell the parents that we have an incomplete picture about this deformities, etiopathogenesis. It is completely treatable, manageable, and results that are obtained are excellent in literature, but you should not use the word curable. There are many centers in Pune and abroad and all over India which are trained in this treatment. Professor, don't ask them, don't become Professor Google. So a lot of parents do a lot of Googling, and on the net, they will always find the worst case scenario. Very few people will put the best case scenario. So avoid doing a lot of Googling, show them websites, support groups, ask them to meet other families. There are a lot of websites that the parents can see and Facebook pages. So we have to deal with emotions of parents. They can be widespread and unpredictable. And these are the various emotions of the parents that we'll have to face. So what to tell them about treatment? You can describe the Ponceti method. You can show them models about what actual clubfoot is. You can introduce them to other parents. Inform them about the cost and NGOs. Tell them that there are a lot of NGOs who will also do free treatment. So don't worry about the cost factor. And then the final question that all the parents ask is that, doctor, when will my child walk? Will my child walk normally? So we did a study on gross motor milestones in children, and we found that the child is likely to have a minor delay of 1 month in motor milestones, and that 95% of the children will walk by 18 months, and parents must adhere to plaster treatment protocol and brace protocol. And in unilateral clubfoot, the calf muscle on the affected leg can be smaller than the other side, and the leg of the affected side is often shorter than the other side. So these are the counseling tips, general tips, which you can give to the parents. Thank you very much.
So that was absolutely excellently Done, Samir. Congratulations on that, and very clear-cut messages and very complete. Ashok, do we take a couple of questions now, or should we take all of them at the end of it?
I think at the end of it, sir, ma'am.
At the end of it.
Yeah.
I can take it all at the end.
So we go on now from Kuch Kuch Hota Hai, we go on to the student of the year and who is really the best one in the class. I request Samir to stop sharing his screen, and I will request Atul Bhaskar, very prominent pediatric orthopedic surgeon from Bombay, to start sharing his screen, who's going to take us through the ins and outs and tips and tricks of the Ponceti technique. And as well as cover a little bit about the role of soft tissue releases. Are they completely defunct now that Ponceti has stepped in? Over to you, Atul.
Okay, so thanks, Samir, for that wonderful presentation. So taking from there, I think Samir has shown us that the spectrum of clubfoot really can come at birth, before birth, and even at mid-20s, and that is the spectrum which we see. And so we have to have a treatment which tailors to everybody. We can't have one size which fits all. So I'll start with a case that this child comes at 3 weeks of age with a bilateral idiopathic clubfoot, and one does the assessment, one does the scoring, you do a Ponceti casting. Counseling is very, very important, as Samir mentioned. And the child, this is how when the cast comes out, the child comes back. So mother is horrified and she refuses the second cast. And I think this is where the challenges come about counseling and about casting techniques. And this is what it's been recommended by Ponceti manual itself, that you have to have an adequate cast padding. You have to make sure that you use the fingers in the right place. Don't put undue pressure, especially in the first or second cast, as the tailor head is very, very prominent here. And since you don't have the full abduction at this stage, it is very easy for the beginners to put a lot of pressure on the fulcrum here and cause this kind of cast sore. So just to go through some of the videos of casting, of course, this is during COVID time. So here you do put a well padded cast, make sure you can go above the knees. Child should be as calm as possible. The first cast is critical, that you make sure that you are able to abduct you are able to lift the first tray and supinate the foot, and that forms the basis of further casting. As once your foot is supinated, you can gradually abduct in further cast. Make sure you don't leave any prominences or indentation in the cast. Keep moving your fingers as you're casting it, and ensure also that once the below knee part is complete, then only you do the above knee part. Don't try and put the entire cast in one go. So as subsequently you give your casting, you have to ensure that your cast goes through this, your casting process goes through these 4 or 5 plasters. Don't promise the parents they need only 5 plasters. You can, as soon as you're able to abduct the foot up to 45 degrees, then you can think of connecting the hind foot. Sometimes the children may be very, very cranky, so it is worth using something to calm or soothe them. And I find this very useful, using a pacifier. So in our children, they're not like the Ponceti clinic. They all are shouting and howling. So parents have their own, they will put on music. I find you can use glucose solution 20% with a syringe, and you can slowly drip feed the baby, and usually they're quite calm. Obviously, follow the Bible. Dr. Ponceti has already laid out the steps. Do not try and modify the regime in any way. So you must follow the sequence of connecting the cavus first, followed by the adduction, the varus, and only then you can cast and do the equinus. The error usually made by the newer surgeons that they try and correct a lot of these components in 1 or 2 plasters. So, and one should understand the biomechanics of it, that as soon as you correct the coronal deformity, the sagittal deformity also improves because of the interlinking of the ligaments. So don't try and force correction in the plane which you don't want to cause a problem. Of course, you score the child with the Pirani score. This is a simple score. It has got its flaws, but at least it guides over treatment. It's not easy to classify clubfoot, which is a 3-dimensional deformity, but at least you have some idea about your correction. So in individual hands, it's a great score to use, and when your mid-foot score comes to 0, that's a good time to try and start correcting the hind foot. There are some problems with the scores, and this has been very, very well documented. The most important is the empty heel, because posterior crease, may not be deep in every child, and it has got a kind of a ceiling effect. So hind foot score of 2 and 3 may actually mean the same thing. What it doesn't assess is the everter strength, and I think that is one of the most important finding now, that if your child has got poor peroneal or everter strength and no fanning of the toes, in those children you have to really counsel the parents that they will need more plasters, they will probably may need more splinting. So it's very, very important that at the outset you can identify these risk signs. Like I mentioned earlier, don't try and rush to cast. Initially you manipulate the feet, try and feel the bones, try and feel the bony contours, move the foot gently to whatever maximum correction you can get, and then only you begin your casting. Don't start casting immediately as soon as the child is on the table. It's worth spending a minute or two to gradually strengthen the soft tissues and follow these steps. Correct the cavus, make sure the forefoot is supinated. Using the first head of metatarsal ray, use the fulcrum, don't put extra pressure on it, and then gradually abduct the foot. So this surgeon attends the first Ponceti workshop and gives a beautiful cast, and then after 4 days the mother comes back, only brings the cast and not the child. So this is not uncommon, when you're trying to cast in a cranky child, or you're not following the principles of casting. This is not an unusual finding. So I always counsel the parents that the child may kick in the first 1 or 2 plasters and may actually remove the plaster. So it's not an embarrassment on your part. So it's very, very important that when you apply the cast, you have that first or second cast which is very well molded, and you make sure your knee is flexed over 90 degrees to 100 degrees, because if you keep too much extension, chances are that the cast will slip, because the foot is still in equinus. So you have to ensure that you get at least 90 to 100 degrees of knee flexion. So this is the third cast application in a child, and you can see after the cast application, the toes on this side are looking a bit pale. What do? Do you leave it alone? Do you change the cast? Or so here, whenever you see this kind of finding, it's very important you don't ignore it. You have to make sure that at the end of your procedure, the child has got a nice pink toes, and there are vascular anomalies in clubfoot. By and large, the commonest cause is vascular spasm, sometimes because of compression. If you're using a tight bandage, especially around the knee in the popliteal fossa, or sometimes when you correct the equinus very rapidly, you will get this kind of pallor. You wait till the toes turn pink. You can wait for about 5 to 10 minutes. Occasionally, one may have to undercorrect, and we may have to redo the cast in case the paleness persists. And these are very important, especially this kind of finding you will get in these chubby feet. Cast slippage, skin problems, vascular issues are very, very common. And so these atypical feet will need a different kind of casting procedure, which I think Rujuta will cover. But you must have a mental picture that whether this foot is, amenable to casting in the standard fashion, or whether it needs a modified technique. And this technique is where you try and manipulate the entire foot rather than just the foot deformities. So this I think Rujuta will cover in her talk. Now, once you've done the midfoot correction, you have to prepare for the tenotomy, which is an integral part of the Ponceti regime. So you must assess carefully that the hind foot is empty. You must only do a tenotomy when you know that you are not able to achieve a good plantigrade foot with 15 degrees of dorsiflexion. And also, you must have at least good 30 to 40 degrees of abduction. Make sure the lateral border is straight before you plan your tenotomy. Now, you must look at the calcaneus, and I can tell you that many times it's not easy to assess the empty heel sign in a chubby child. So occasionally, if a child has come to me with a relapse, or if I feel the hind foot is not getting corrected, it's worth doing an X-ray and seeing whether you're getting any mobility. Also, you look at the skin crease in the soft tissue contour, and you can find the crease is really deep. The key thing is you should not dorsiflex the midfoot, because it would lead to a midfoot break, and that's why sometime in a chubby child I will not hesitate to do intra-op X-rays. And you have to ensure that your hind foot is mobile. If you feel it's not mobile, you can go ahead and do a tenotomy, and then you will see that this calcaneum moves into dorsiflexion. And this is very important, especially if you're not sure about a correction, and sometimes it is not easy to assess the hindfoot. So X-rays have a limited role, especially if you're not sure about the hindfoot correction. But don't do this. It's worth taking an X-ray, spending an extra half an hour rather than creating a midfoot break, because this causes more challenging correction. You have to start the process again. You have to do a reverse Ponceti casting, and it becomes difficult to counsel the parents that you've caused a midfoot break, and this is an iatrogenic complication. Tenotomy, of course, there are various ways to do it. I prefer a short anesthesia, short GA, where the child is completely relaxed, but I find many people in the West are doing it in the clinic. You can use a 11 number blade or a needle. You always go from medial to lateral. You remember that the tendon is not really posterior, it is slightly lateral. And as you put a knife inside, you dorsiflex the foot while cutting, and then you feel a sudden give. And then you can get this kind of 15-degree dorsiflexion. So normally I would feel the tendon with a small mosquito. You palpate the borders. The tendon is always lateral to the midline, never in the midline. Feel for the taut tissue and always cut medial to lateral. And you should not have a scar more than a few millimeters. One can use a synthetic cast. I usually reserve this for older children, especially if they're more than 6 months of age, because the gypsonoplasters can be broken by active kicking with some of these older children. So to maintain the correction, sometimes you apply a synthetic cast so that the child doesn't come out with the cast coming out prematurely. There are some problems in the tenotomy. You can see there are scars placed medially where you cannot do a complete tenotomy. Sometimes it's placed far medial and you can't reach the tendon, and so there's a very high chance of relapse when you don't have a complete tenotomy or a complete correction at the final cast. Occasionally, when you cannot feel the tendon, you can do what is called a forceps-assisted tenotomy, which has been very well described. And then you can use a small mosquito. You can bring the bulk of the tendon out, and you'll be surprised how thick this tendon is. And you cut the tendon under vision, and you can then put a cast. And I find this very useful for these very, very chubby feet, where you can actually feel the entire tendon. Give the final cast, and then again the cast problems don't get resolved. You can get problems in the skin because the child has been in plaster for about 4 to 5 weeks. So you always counsel the parents that there will be some skin changes on the affected side. Bracing again is an integral part of the Ponceti regime. So there are a lot of different types of braces available in the market, which can lead to several problems. And we've got a whole series of these where the child has been applied with this kind of brace right at the outset. And because the skin is delicate, they get these the skin marks. So we've tried to modify this by using a custom-made brace which is properly fitted. Use cotton socks, and we've kind of looked at the causes of failure, brace failures after full correction. And there are some early failures because of pressure sores, intermediate failures because of size issues. Child will start turning, he will start removing the laces, and late failures because the child starts to stand. And I think that is a challenge at every stage of treatment, and it's worth counseling the parents. There are other braces which are available. They're expensive, which don't have a lace, but you have to counsel the parents that getting a brace is not difficult with the current NGO facilities with us. So if you put a rigid brace, you have to ensure that the child wears a proper sock, otherwise they will get this kind of marks, and the parents will stop the compliance. You can get such kind of cellulitis as well. This child needed antibiotics because this Velcro straps were hurting the child so badly they got a severe infection. And late brace problems when they don't change the brace, especially in COVID times, the child is wearing the same brace for 6 months. You can see this kind of skin callosities they get. So this can lead to poor compliance as well. And we've shown this almost 14 years ago about the brace problems in children, and which can affect the compliance with the ill-fitting brace, and especially if the foot is under-corrected. This is very, very important. If your foot is under-corrected, the brace compliance is always very, very poor. By and large, it's a very, very satisfactory technique. If the child is following up well with good compliance, you can end up with a good result, and 90% of children will have a satisfactory outcome. The role of surgery in the Ponceti era is I think is diminishing. in my practice, generally I would do it when I feel there's a poor follow-up of the casting program, when there's incomplete correction, especially near the peri-walking age around 10 to 12 months, where the parents are really not keen to undergo multiple casting. Somebody who comes back with an incomplete correction at 2 years, and again the child has to now attend school and a toddler play group where the parents really can't come for regular casting. I would definitely offer a surgery, but only after a few plasters, maybe a couple of plasters to get the skin aligned, skin stretched. Also, it will ensure that the parents are going to be compliant in the post-op regime as well. So 18-month-old child who comes first time like this he's a walking child, and he's walking on the lateral border, he will get callosities. Ideally, you can cast him 4 or 5 plasters and then do a minimally invasive procedure. This child is coming from a village, so they wanted to get the surgery done. So we opted for surgery. This child had 20 plasters done at an outside center, and I was surprised that the parents actually agreed for 20 plasters. Now they're totally fed up, so they opted for surgery. And the surgery is always an a la carte approach. You cannot offer one surgery to every child. You have to look at the deformity which is persistent. So you start off with a cavus correction by doing a plantar fasciotomy. If the posterior structures are tight, you do a posterior release. And what we do for the forefoot is an abductor hallucis tenotomy, which we've described. In a dynamic foot, we can always do a split tendon transfer. And in a late presentation, you have to do a full blown release along with the column shortening. So this child was an 18-month-old child, had a bilateral clubfoot, and we do 1 foot at a time, but this was a hemi-Cincinnati approach. So this child underwent surgery in the same sitting. This is a different child. You can see the scar of the hemi-Cincinnati. One responded to Ponceti, and so this posterior release is very, very rewarding. I'll show you some slides of this. Also, the child who, when they present with this kind of dynamic over correction, over supination, I always add abductor hallucis tenotomy as well. I don't know what the benefits are, but certainly it helps reduce the forefoot adduction, and we are still looking at our long-term results with this. So I would combine this either with the posterior release or a TA tenotomy. Like this child underwent abductor hallucis tenotomy with a posterior tenotomy. So this is a child, 22 months of age, had a relapse following a tenotomy. And this child, we did a hemi-Cincinnati approach, did a posterior release, open TA lengthening, and then ankle joint capsulotomy, and a subtalar capsulotomy till we could get 15 degrees of dorsiflexion. I can tell you, when you do a tenotomy, it's not a benign procedure. Whenever you open these or you revise these, you will find the scarring is right up to the capsule. And occasionally, when you do a retenotomy, you may not find the gliding. So in those cases, it is better to do a mini open, because you should try and get at least 15 degrees of dorsiflexion with whatever technique you're convenient, you're able to do. So retenotomy sometimes doesn't work very well, and I've seen that it doesn't glide. So I'm happy to do a mini release, and the incision heals very well. In the older child, they will need a comprehensive release, and that I mean is a posterior medial release along with the lateral release, and there are various ways to do it. So in my hands, I do it prone with what is called the Cincinnati approach, where we take the incision right from the base of the first metatarsal up to the lateral malleolus, and so we attack the structures on the medial side first, isolate the nerve, which is always free from the neurovascular bundle. So release the FHL, the FDL sheath, the tip post, release all the capsule on the medial side, and then in the end you repair it with proline, and you always suture in equinus, and you can see the release of the fasciotomy as well, the plantar fasciotomy. Sometimes the foot looks very ghastly like this in the older child, where when you've done a comprehensive release, and you can see that the amount of correction you can get and the amount of skin which is left uncovered. But believe me, this really heals very well if you cast them in equinus for the first 4 weeks, and then you gradually stretch them. So this is an example of the skin closure. I use absorbable stitches. Always I use a wire, a talocalcaneal wire, and a wire from the first ray to the calcaneum to maintain the correction. Occasionally you can even leave the entire thing open if you want, especially if the skin condition is poor, and you will find that you can come back in 3 weeks and close them. I've very rarely done that. I always close the skin primarily. And you keep the cast in equinus, and you will find after 4 weeks, as the skin heals, you can come back and correct the deformity. You can get a well-healed scar without any problems. The turquoise release, which is the classical posterior medial release, either you can do from a straight medial incision, or you can do a dual incision like described by Attenborough. But the key structure is the abductor hallucis tendon. The abductor hallucis muscle is the door to the tendons. Once you elevate this muscle, you expose the medial structures, the medial tendons, the medial capsule. So you must do a very good excision of this muscle and let it stretch itself. And then you can go underneath and expose the tendons and the capsules. So these are structures to be released. I will not go into detail. It's all there in in theory. But the essential part is to preserve and repair the sheath of the tibialis posterior. Always derotate the talus. That is the key thing. After you do all this fancy release, make sure you are able to turn the talus from external rotation to internal rotation. Put a pin. Put a cast for 12 weeks with an interval cast change at 4 to 6 weeks to check the wound. You can remove the wires at 8 weeks. Get the child measured for splints, and finally remove the cast at 12 weeks. Now, of course, surgery will always lead to some stiffness, but it is better to have casting for a good amount of time so that the compliance with the splinting is good. And you can get a good result following a release like this. So this child had a tip and transfer with a Cincinnati release, and you can see the foot is very well plantigrade. It is always better to get a mild flat foot than a cavus in these clubfoot children. So this is another child who underwent a posterior medial release. I always get the splints ready by 8 weeks when they undergo a cast change, so that the splints are available, and the child then continues to wear these full time. Role of tip and transfer again is very limited in my practice. About 30 to 40% of children, typically around 3 to 4 years of age, when they have dynamic supination, and you can do a split tip transfer or a complete transfer. The key thing is to identify the tendon from the medial side, harvest it here in the lower part of the leg, and then pass it through the third cuneiform. So this is how I would do it. I would harvest the tendon from a small incision, and then suture it on with the button underneath there with the felt, so that you can cut this at the end of 6 weeks. And you can find that after the tendon transfer, the everter power really improves dramatically. So this is a child who underwent this procedure. You can see the tendon is harvested. I use a tendon stripper to harvest half the tendon, and then you can either use an anchor for the older child, or you can suture it with a drill hole in the third cuneiform and over a piece of felt. For the older child, I've also used a 2.5 mini anchor made by Smith & Nephew. And you can see the results of tip and transfer. They are very, very rewarding. Occasionally, I've combined this with a medial release as well as sometime abductor hallucis stenotomy. And you can see as the child is dorsiflexing, you can get a good eversion of the foot. And you can see it here, the wound is well healed. That's the line of pull, and the feet are plantigrade. So finally, tips and tricks in Ponceti: never do pronation. Always use the head of talus as fulcrum, but don't press it too much. Don't try and correct equinus before you do everything else. Always plaster above the knee. Don't try and cast in an active child who's fighting against you. Make sure the child is calm. Don't use excessive force. Always have a good assistant. Have adequate padding, not too much or too less. And you must have good molding. Ultimately, the collapse in bracing will lead to relapse, and we found that in our practice, 70% of relapses occurs because of poor brace compliance, and that has been very well described. So the maintenance phase is very important, and I think Alric is going to cover the relapse clubfoot, which we've already covered in 2013. The relapse pattern is not varies depending on the abduction orthosis the child uses, and I think that is the key today. You may get a good casting outcome, you may get a good brace outcome, but you have to kill the relapses, and that is the real challenge. With children coming from various parts of the country with limited finance, with limited resources, and that is the next challenge. So I think I will end my talk here. If there is any questions, we'll take it later. Thank you very much.
So thank you for for an exhaustive review, Atul. And as you've thrown open the challenge, like Professor Ponceti, we have Professor Alaric Arujis, and like Clubfoot keep coming back. So kabhi alvida na kehna, they keep coming back, and relapses do come. And let's ask Dr. Alaric how to deal with them. Over to you, Alaric.
Yeah, thank you, Rujita. I think that was a great exposition of an important topic by Atul, and he has set the stage for me to speak on the next aspect, which is the management of relapse. And I don't think there's anything in orthopedics, especially in pediatric orthopedics, which has changed so radically over the last 20 years as the way we treat clubfoot. I remember the first 5 years of my practice, when we began, we were doing almost 150 to 200 soft tissue surgeries per year. And within a span of a year, once we introduced the Ponceti method all throughout India from 2003 onwards, the rates of radical surgery dropped so drastically that's almost amazing to see. So what I'll cover here today is how do we manage relapse? And because the Ponceti method is the most important technique that we're using, I'll focus much more on how do we deal with the relapse following the Ponceti method. So if you read the literature, you'll realize that most of the relapses, in fact, almost 2/3 of them, occur in the first 2 years of life. And that's what Ponceti has shown from his very long-term studies. But of course, even up to the age of 5, there is a chance for relapse. So he has shown that 1/3 of relapses occur even up to the age of 5 years. If you read the various Ponceti publications that have come about since 1963, the initial results of Ponceti showed a very high recurrence rate of almost 56%. And that's the reason why this method did not become very popular for the first 20 or 30 years after Ponceti established it, because though he had a correction in almost 90% of cases, if half of them recurred, people were not so keen on this particular technique. If you realize, I think the first thing to understand is how to define a relapse or a recurrence. And that's something that many authors struggle with. I think the best definition would be that if you have a reappearance of even one or more components of the cave deformity, that is cavus, adductus, varus, or equinus, that requires further treatment, that would be the definition of a relapse. So there is a subjective element to this definition, no doubt, but minor degrees of reappearance of a deformity, especially things like mid-foot abduction, a forefoot adduction, or a mild amount of cavus, can be easily ignored if it does not cause any functional or major cosmetic problems. We must understand that recurrences of two types, and they may coexist together. It could be either static or dynamic. And there are various ways in which you assess a recurrence. One way is to use the Piranha or the Demeglio scores. They were actually used initially to define the severity of a deformity, but we could use these scores as a surrogate for relapse as well. This is an excellent article that came out from Matthew Dobbs in 2004, which said, what are the main reasons for why a recurrence occurs? And he has shown that the three main or four main causes are the failure to gain full abduction during the correction phase of the deformity, failure to use the foot abduction brace, an overactive tibialis anterior causing a dynamic supination deformity, and a basic growth spurt that happens in children. And there is a small percentage of cases where the cause really is not known. Now, the early recurrence of a deformity recurrence in the Ponceti method, if you look at the various causes that Dobbs enumerated, the two main causes are these. And it's interesting to note it took Ponceti several decades to understand that these are the two important causes for the relapse. The first is the failure to achieve 70 degrees of abduction in the last cast. And that's especially true for young babies who are less than 1 year of age. This is not, of course, true if you're treating older children who have less supple deformities. And the second is non-compliance with brace wear. This is an interesting study that came out of Ponceti's own institute. He looked at the first 35 years of applying his method, and where he did not use that abduction up to 70 degrees, he found that the incidence of recurrence was as high as 48 to 50% in the first 2 years of life. But the minute in the next series of patients over the next 10 years, where he started using 70 degrees of abduction in the last plaster, it dropped drastically from 50% to 15%. And that's a very radical drop in recurrence rates for a simple technique of abducting up to 70 degrees in the last plaster. The second important reason for a recurrence, of course, is non-compliance with brace wear. And there are various studies which have looked into that, as I've quoted again, Dobbs study which showed, and Ponceti studies which show that if you're compliant with brace wear, the risk of relapse is very less. Whereas if you don't comply, you have a very high risk of recurrence just because of this one entity, which is failure to use the brace. Here's a study from New Zealand which showed that when looking at 51 children with 73 club feet over a minimum period of 2 years, defining recurrence as one requiring either a minimum surgery or a major recurrence as one which required a full-blown surgical approach, Hamish Crawford found that 40% of the patients had a recurrence, and only half of these had complied with the bracing protocol. So what he and further people have shown that if you don't comply with the bracing protocol, you have a 5 times higher chance of developing a recurrence. And interestingly, there's no significant relationship of recurrence with severity of presentation, the time at which you start the casting, the number of casts that you apply, or your ethnicity or family history. So the two main factors for recurrence are the failure to achieve 70 degrees of abduction in the last plaster and non-compliance with the bracing protocol. How does one recognize a relapse? I think we use our standard methods of look, feel, and move. And therefore, the first step is to look how the child is standing, walking, and squatting. I think squatting is a very important method to diagnose early relapse of equinus. That's something that's inherent in our Indian population, that people, especially in rural areas, require to squat. And unless you have at least 30 degrees of ankle dorsiflexion, you're unable to squat. You'll have an early heel rise. And that's the first way to diagnose an early recurrence of equinus deformity. The second, of course, is an active measurement by actively trying to measure the extent of dorsiflexion. Another good method is to stroke the sole of the foot and to look for the presence of a dynamic supination. And of course, as I mentioned, you can use the Pirani or the DiMeglio scores as surrogates for relapse, but of course, they have not been validated for that. But it's been described that if you have a Pirani score of 1 or more, or a DiMeglio score of 5 or more, then that's an indication of a relapse. So here you can see a 2-year-old child who has treaters dysplasia. You can see on both sides he has constriction rings. He's got a minor amputation of the toe on the left side. And as he's walking, you can notice that he has this recurrence of a deformity. It's a combination of static and dynamic both, because as the foot is swinging, you'll realize that there is a dynamic supination of the foot, but even in the stance phase, there's presence of some amount of forefoot adduction and the presence of a heel varus. So here's a combination of a static and a dynamic supination. Now, how does one deal with this at the age of 2 years? Just to bring to your attention, this child was treated at birth with 5 serial plasters and a tendoachilles stenotomy. He was not compliant with brace wear. So at this young age, the importance is that the recognition is crucial. A lot of us try to bury our head below the sand and pretend as if it does not exist. But Ponceti has very clearly said that the more you ignore a relapse, the worse it becomes. We must be able to convince the parents that there is an early relapse, and even if the foot is correctable passively, we must begin the treatment early. The recognition, as I've already shown you, is loss of dorsiflexion or an early heel rise, the onset of heel varus or weight bearing on the lateral border of the foot, an onset of midfoot adductus, and as I've said, the child may have a dynamic supination as well. So at this age, we go back again to the Ponceti method. It worked in the initial phase, it will work again now. And it's important to convince the parents that this is not a failure of treatment. Despite our best efforts, a child who's treated with the Ponceti method will have a risk of relapse. And I think the best way to counsel the parents is at the time of instituting the brace wear itself to tell them that despite the best efforts, the chance of relapse is present. If you wear the brace, the relapse rate is low. If you do not wear the brace, you have a very high relapse rate. But if it does recur, we can always treat it back again with the same technique that we used at birth. So here, go back again to the Ponceti casting. The good thing is here, if you pick it up early, within 2 or 3 plasters, you can correct the foot again. Do not hesitate to repeat a tendoachilles stenotomy if you find the dorsiflexion up to 15 degrees is not possible. And then go back again and reinstitute your bracing protocol. And this time, try and ensure as much compliance as possible. What I would not do is a tibialis anterior tendon transfer. In fact, the worst results of a tibialis anterior tendon transfer are when it's done in a child who's less than 2.5 years old. And there have been several studies from literature which have shown that. So if you have a younger child who has a dynamic supination, Try and correct that with the Ponceti plasters. Try and use the brace as much as possible, but defer your tendon transfer till at least 2.5 and ideally till the age of 3. So that brings us to dynamic supination. And Atul has already touched upon some part of it. It occurs because, as we said, of a tibialis anterior, which is overactive. It can be subtle to diagnose. But the key way of diagnosing it is during the swing phase of gait, when you find the foot goes into dynamic supination and the child strikes the foot on the lateral border during the stance phase. So here's an example of a 3.5-year-old boy. As you can see, statically the foot is placed well. But once he goes into swing, the foot turns inwards, and you can see he lands up on the lateral border of the foot. And this is the typical presentation of a dynamic supination. This should not be missed. It's very easy to pick it up on a video like this. And I encourage all of you to use your slow motion videos on your smartphones. Every smartphone since the last 3 years or so have a slow motion facility, and that picks up dynamic supination really well without the need for any fancy gait analysis or other things. So how do you manage a child in this age group from 2 to 5 years? Remember that if you have a static deformity, you must correct that first. You cannot do a tendon transfer in the presence of a static deformity. So whatever residual static deformity must be corrected with Ponceti plasters. Usually 2 to 5 plasters may be required. Again, if the equinus does not permit a dorsiflexion to at least 10 degrees, repeat the tendo-Achilles tenotomy. Some of these children have a residual cavus. You might be able to correct that with the Ponceti plasters, but occasionally you might need to do a plantar fascia release. And once the static deformity has been corrected, that's when you should go ahead with the tibialis anterior tendon transfer. You always do a complete transfer of the tendon from the navicular and the first metatarsal to the lateral cuneiform, and then cast the child for 4 to 6 weeks, depending upon the age of the child. So this is a fairly old technique. It's not something new. It was described, in fact, in the 1940s, and it's often called the Garceau technique because he was the first one to report the results of a tibialis anterior tendon transfer. And in his technique, he used a 3-incision approach. I'll show you some quick pictures of how the technique, or what technique we actually follow for doing the tendo-Achilles, for doing the tibialis anterior tendon transfer. We follow the 2-incision technique that has been described by Ponceti, which is a modification of the Garceau technique. You don't need to have a 3rd incision over the front of the leg, but 1 incision over the medial aspect of the origin of the tibialis anterior tendon and 1 over the lateral most cuneiform, where you're going to reinsert the new tendon. So your first incision is, as I've said, identify the tibialis anterior tendon, trace it all the way down to its insertion onto the base of the first metatarsal and the navicular so that you get enough length of the tendon, and then detach it completely from its insertion, as you can see down there. Then you have to release a little bit of the tendon sheath as you go proximally. If you do not do that, you will have a tendon which has an oblique line of transfer. You know, one of the principles of tendon transfer is to have a straight line of pull. So we must be careful not to release the extensor retinaculum on the dorsum of the ankle, because this will cause a bowstringing, which is very unsightly. Release just enough of the tendon sheath so that when you transfer the tendon, you have a straight line of pull. Then you can take a modified bunnel or a whip stitch through the tendon, which all of us are quite used to while doing tendon transfers. The next step is to identify the lateral cuneiform. And ideally, if you have a C-arm or an X-ray, it's very easy to do that. So in line with the 3rd metatarsal, which is the axis of the foot, you'll find that's where you have the lateral cuneiform. You should never transfer the whole tendon to the cuboid, because that can cause a very severe valgus deformity, which is far more disabling than an adduction deformity. So the ideal bone to transfer it to is, as you can see, medial, middle, and the lateral cuneiform. And that's which is in line with the axis of the midfoot, and that's where you should be going. Take your incision over the dorsum. You require hardly a 2 centimeter incision. Separate out the extensor digitorum brevis muscle, and then you have the long extensor tendons of the toes, which should be kept to one side carefully, and then you're straight down onto the 3rd cuneiform. Elevate the periosteum over it and identify the bone, and then make a small drill hole, as you can see here, through the lateral cuneiform, going in a straight perpendicular to the direction of the foot. Be careful as you exit out from the sole of the foot, because you have the median and lateral plantar nerves and vessels. So be very careful when you exit out with your drill. As soon as you give way through the bone, you stop your drill. And then I use a straight hemostat to widen and round that hole up in the lateral cuneiform. That helps the tendon to glide in really easily. So you must have a big enough hole. And I've seen commonly people struggle trying to put the tendon through that hole if you don't widen it enough. The tendon itself is about 2 to 3, sometimes even 5 millimeters in thickness. And unless you make a good enough hole in the bone, the tendon will not glide through and will just sit at the edge of the bone and not adhere to it properly once it heals. So the next step is through that second incision, deliver the tendon from the first one. And this is the time to be sure that there is no fascial coverings or tendon sheets, which is preventing a straight line of pull. If there is anything which interferes with that, you must release a bit of the tendon sheets, but do not release the extensor retinaculum. Otherwise, that will cause a bowstringing of the tendon. And once you've done that, you put you do a pull-out suture into the sole using a straight needle. Again, be careful here because you have the medial and lateral plantar nerves and vessels. So be very careful. The center of the foot is the safest part because the nerve has already divided and gone on either side, and so the vessel. And then you can tie it over a foam or a gauze. I would never use a button directly on the skin because that can cause a severe amount of skin necrosis. If you're using a button, you can use it over a gauze or over a piece of foam and tie it off like this. And it's important that when you finish the procedure, the foot can still drop down into some amount of plantar flexion. Do not tighten the tendon in a severe amount of dorsiflexion because that will cause a dorsiflexion contracture. So once you finish with the tightening and the closure, the foot must be able to fall or drop down by 10 to 15 degrees to ensure that you're not over tightened the tibialis anterior. And then you cast this for about 4 to 6 weeks. And according to Ponceti, there's no need for a bracing after this. We are more on the cautious side. And I would still institute bracing for at least a year after you've done the tibialis anterior tendon transfer, at least in the night time. So here are some long-term results from Ponceti's own institute. Really long-term results of tibialis anterior tendon transfer with a follow-up of 37 to 55 years. And they looked at the initial series treated by Ponceti from 1950 to 1967. They did a very detailed examination of the of clinical aspects, radiographic evaluation, pedobiographic analysis, and EMG as well. And they found that this surgery is very effective in preventing a long-term in preventing additional relapse and getting a long-term good function. Of course, you must remember that even after this, there is a small chance of a relapse. In fact, again, Jose Morcande has shown that there's a 15% chance of a relapse even after tibialis anterior tendon transfer. So don't be too complacent after this. A small percentage of patients have neuromuscular deficits. And as Atul rightly pointed out, if they don't have a fanning out of the toes and good everter activity, these are children who have some subclinical neuromuscular deficits and who have a higher chance of relapse. So be watchful right throughout childhood, especially in the first 5 years. So here are some other factors predictive of secondary recurrence after the tibialis anterior tendon transfer. Again, it has been shown that if you do the transfer before the age of 2.5 years, you have almost twice an amount of recurrence than if you do it after that. So therefore, my recommendation is that delay the transfer to ideally between the ages of 3 and 5, where you have the best chance of success. So the take-home messages is that the relapses are part of the Ponceti method of casting. We must explain this to the parents right up a priori before we start the treatment itself, so they are aware of the importance of bracing. We know that achieving that 70 degrees of abduction in the last plaster, especially if you have a child who's less than 1 year of age, and the important adherence to the brace compliance are the key to preventing early relapses. The good news is that most of these relapses are supple. They are amenable to casting, tenotomy, and bracing. And occasionally, if you have a dynamic supination, you might need to do a tendon transfer. Be careful that we are vigilant for relapses, at least till the age of 5 years. But every clubfoot should be followed up entirely till skeletal maturity. Thank you very much for your attention. So our next speaker is Rujita, and she will be speaking on the atypical and syndromic clubfoot. So Rujita, if you're ready with your talk, we can start with that.
Yes. Ponceti itself has a huge learning curve, and like we say many times, dil hai mushkil. So it's good to think that the technique is easy, but when you actually go into it, you realize that there are many things that one can go wrong. So let's see what commonly goes wrong with people who don't really do Ponceti casting too often, and even in our own hands, we've had this before. So for example, let's take this case of a 3-month-old child who came with a clubfoot, treated properly by serial manipulation and casting. It took longer than expected. About 9 casts were applied because the cast had slipped 4 times in between and the surgeon had to start all over again. So what happens here is that the deformity persists and it has failed to improve over the last few casts. And the only reason that it has failed to improve is because surgeon has failed to realize that what has gone wrong over here. So this, to my mind, make no mistake, is a typical iatrogenic clubfoot, which is known as an atypical clubfoot. It is very different from the complex clubfoot, as we'll see later. And the reasons for it are clear-cut. There is too much padding applied because sometimes when you're a beginner, you may think that you don't want the plaster cast too tight and you don't want vascular problems. The baby may have been crying and fidgeting, so the cast is not really well molded. And the foot slips upward inside the cast and you don't even realize it. And hence, the foot deformity may start looking worse. So how does this happen? You started with a nice supple clubfoot and here you are with an even more deformed clubfoot. So how will you identify an atypical clubfoot? So there are a few characteristic hallmark features like the plantaris, which I will explain, which is, I'll show you some x-rays and CT scans to clearly point out how it's different from a normal clubfoot. The forefoot here is in total equinus in plantaris, and the short great toe has actually cocked up because it is in hyperextension. And there is an apparent tibial bowing because there has been an abnormal force which has got exerted at all the wrong points inside the cast. So you have ended up causing a midfoot break, you've ended up causing a almost squashed foot and a squashed heel, as you can see in both these pictures here. In addition, there are some very, very clear-cut features you will see, like a rigid equinus and a completely squashed heel over there. You can see a flattened heel pad there. A deep crease above the heel, as you can see here, both on the dorsum and on the plantar aspect. You see a plantar flexion of all 5 metatarsals here, which is the plantaris, and the transverse crease on the sole of the foot and a short extended, hyperextended first toe. So to show you that these creases, these pressure points, and this very, very deep crease over here, sometimes it goes all across to the medial border. And you can actually make out in this that the forefoot has actually become hyper abducted, whereas the midfoot and the hindfoot have lost really their alignment with the rest of the foot. And this happens because the foot is not really abducting through the subtalar joint when you're exerting abnormal pressure or your pressure at the wrong point, because in Ponceti it's very important where the pressure should be exerted and what the foot should pivot around. So therefore you get an atypical clubfoot. So if you can see here, to show you again another child with the deep medial crease growing right up to the medial border there, right across the midfoot. Again, to show you edema on the dorsum of the foot, which means that the skin, the soft tissue, the muscles, everything is inflamed over here. And you can see some pressure marks developing out here and erythema on the dorsum of the foot. So when this happens through your clubfoot journey, what should you do? We'll take a look at that shortly after now examining. There are researchers who have gone into x-rays and CT scans to show you what is happening inside the clubfoot. As you can see here, the heel is not corrected. There is a clear-cut midfoot break. There is a toe crowding of all the 5 metatarsals, and all of them are in a very deep, sharp equinus there compared to a normal normal foot, which is in the X-ray below here. Again, image intensifier images to show you the same thing which you saw on the earlier X-ray, the heel in equinus, midfoot break, and a deep plantaris. And this is a normal foot. So you can compare how badly this has been quashed inside the plaster. And a 3D CT scan to show you the same thing. If I may orient you, this is a lateral view, and this is a view from the posterior. So you see here that the heel is still in equinus and disconnected. And all 5 metatarsals over there have virtually taken an 80-90 degrees dip in equinus. which needs to be addressed first when you're dealing with an atypical clubfoot. So the first and foremost thing that you will do is leave the child without a cast, which is known as a cast holiday. So stop casting for a few days. Sometimes you may need to do that for a few weeks. When will you decide what's the end point of stopping casting or to resuming a new set of casting? The end point is defined as till the great toe actually becomes longer, the heel is the great toe is no longer appearing contracted, and the child has started moving around a bit, and some mobility has been restored, some skin changes have started coming, and it starts looking normal. After then, you will start manipulation using a two-thumb technique, which I will show you in figures as well as in a short video. So this is how you see the skin changes have all gone. This is restored and it's looking supple as it were before. The foot is of course looking shorter here, but the deep crease over here which you saw has started disappearing, and even the roundedness of the heel has started coming back. The great toe has started looking straighter. This is how now, when compared to the normal foot, the foot should start looking. Then you resume the Ponceti casting all over again. But now you will adapt your technique. And how is that? You will stop abducting the foot. You will allow the foot to relapse back for some time and then work on the dorsiflexion only, because that is where the problem lies. The pathology now is in the forefoot and just gone into severe plantar flexion, the plantaris, and therefore you need to start bringing it back into dorsiflexion so that it aligns with the midfoot now and comes in one axis. How do you do this? How do you correct the plantaris? You dorsiflex the first and the fifth toe together. So if you see both the thumbs here, they are pressing equally. In a routine Ponceti, you give pressure only on the ball of the great toe to eliminate the cavus. In a plantaris, you will give equal pressure on the ball of the great toe as well as the little toe. And you gradually bring it back, and this crease starts opening out as you can see out here. Then you dorsiflex and dorsiflex gently, just enough, sometimes in a couple of casts before you get it restored into full abduction. When the abduction stops, sometimes you may have to do an early Achilles tenotomy. In fact, don't aim for too much abduction at all over here. Once the deformity is corrected, you may require a modified FAB, or you may actually require to give a AFO. And in some cases, we've even continued a couple of casts after the tenotomy, and that is well known. Once your equinus, the dorsiflexion is corrected, the equinus is corrected, then you may give a little more abduction. So if I could quickly show you here the technique by a video, very, very gentle manipulation, just restricted to the forefoot, pressure on the great toe, pressure on the little toe, and just enough to maintain it in bring it back into neutral. Again, the same manipulation being done over here, and hold it for some time. It's important to let the soft tissue settle down there. And as if you can watch the video here, there's absolutely no manipulation being done to the midfoot or the hindfoot. In fact, the talar head is covered. You can still see the great, the first toe little adductus. And when you're doing the casting, again, remember to maintain the pressure, as you can see, equally on both the feet. Mold your cast well, mold the arch of the foot, and carefully improve the dorsiflexion. Another tip here is to maintain, when you're going above knee, mold behind the knee very well, so and the thigh, so that the cast doesn't slip off all over again. And a little bit of hyperflexion at the knee also has to be done. This has to be extremely gently done with a nice quiet baby, and focus only on correcting the plantaris, then go into early tenotomy, and then go into a abduction if need be. So if handled well, an atypical clubfoot also can be restored back to normal, and these are some of the results post-treatment: fully corrected, supple, and fully functional. Now this is very, very different. This is again a clinical picture to show you how well it is corrected, and complete restoration of all the tibio-talar axis, and both the feet are straight, the lateral borders are straight, and this is as good as a normal foot. And another important tip here is to, when you're giving the foot abduction orthosis, don't set the angle of abduction to more than 30 degrees of external rotation, as you can see out here, Normally, you try to give this angle at about 70 degrees if it's a unilateral club foot, and if it's a bilateral club foot at both sides 40 degrees. But in an atypical club foot, you will restrict your abduction because here the main goal is not to hyper abduct and cause a midfoot break all over again. Now, how is this very, very different from a syndromic club foot, or what is known as the severe or complex club foot? People get confused between the nomenclature of an atypical and a complex club foot. Remember, a severe or a complex club foot is ideally a syndromic club foot where you have marked supination. The calf is also very, very hypertrophic. The talus is extremely flexed and internally rotated. As you can see over here, it is virtually more than 180 degrees severe adduction and a cave is there. And the entire foot is hypoplastic, almost 1 centimeter shorter if it's a unilateral case. These children are syndromic. You should do a good general examination. They may have associated hip and knee contractures. Sometimes even in the spine, there may be issues. There might be hemimalias. There may be several other dislocations associated with that. So that is what is going to tell you that this is rigid and this is not going to be amenable too much to your casting. You may counsel the parents that they are very resistant and the cast may fall off after the third or fourth if not done well. So again, you lower down your goals and you restrict yourself to try and give only a few degrees of abduction. You may need an early tenotomy, but they also can be treated successfully if you adapt your technique well. You emphasize on dorsiflexion in it and you do your cast greater than 90 degrees at the knee using flexion. So you use the similar principles to what you did in atypical club foot for successfully treating these syndromic club feet. Because your basic goal is to get a braceable club foot, braceable foot at the end of your treatment. And traditionally, it has always been believed that these are going to need soft tissue releases or very massive surgeries because in most of these syndromes, the suppleness of the muscles or the contractility of the muscles, the excursion itself is limited. They have associated contractures, and hence there was a very high propensity to go towards surgery for these children. But at Wadia, we recently published one of the largest series where we have shown that it is possible to treat with the typical Ponceti technique, non-idiopathic and neuromuscular syndromic club feet. What did we do? We looked at two groups of patients compared with idiopathic feet and syndromic feet as regards to age, the Pirani scoring, which was noted both pre and post casting and at follow-up. We studied whether they required higher number of casts and what was the tenotomy rate in them and what was the brace compliance. And outcome measures were whether we had a good success rate comparable to the idiopathic club feet, what was the failure rate, whether any secondary operative procedures were needed. If so, then what type of secondary operative procedures were needed, what was the follow-up and recurrence rate. And this is what we found in our study, that we had almost 146 in the non-idiopathic group, 146 feet. We saw that although our age at presentation, the mean age was higher, the initial severity of these syndromic feet was almost comparable to the idiopathic club foot. The total number of casts required were of course higher. We had a very comparable follow-up, and we found that we have a very, very good initial successful success rate, and the need for tenotomy was also as much as the idiopathic group only. But however, what is significant, and this was a significant p-value, is that syndromic feet will tend to have a higher relapse rate. So you have to be alert and ready to manage them, and you may need to use limited posterior releases or at times fixators if a recasting does not work in non-idiopathic club feet. However, your first line will be to go back to the casting by Ponceti technique, and only where it fails, there you will use surgical methods. How does our study compare to the literature? It's almost at par with the rest of the world literature, except that our mean age was higher, our follow-up was almost equal, and our initial success rate was as much as any other paper, in fact, better than some series. And relapse rate was as expected as compared to other series, but it was significantly a larger sample size. And hence we concluded that it can be successfully applied to idiopathic and non-idiopathic and syndromic club feet, but with caveats like For example, this 5-year-old child now, who was initially Freeman-Schendel syndrome, treated with a typical Ponceti, came back with a relapse, had to be recasted, and yet she relapsed again. And there we had to just do a limited posterior release, as you can see from the scar there. But she achieved beautifully plantigrade and functional feet at the end of a 4 years follow-up. Here again, a MMC 8-year-old child with a 4-year follow-up. In this condition, there is hardly any muscle power there to maintain your correction. Hence, although treated with casting, this child had to go an early tenotomy, and with the casting, Ponceti casting itself, we were able to maintain him on a 4-year follow-up. So the message that I would, another AMC child with a CTV and a CDK and hand contractures as well, treated with Ponceti casting, relapsed, and again came back with treated successfully again with the Ponceti casting, and that's her follow-up. So even relapses in these syndromic children can be recasted and they can do well. If they do need surgery, then the amount of surgery or the morbidity associated with it definitely decreases. And by far, there are very, very few conversions into open surgery needed for these children. The Ponceti technique in non-idiopathic CTV does have good results, so you should use it as your second line of defense as well. This was one of the largest prospective series from a single center. I would recommend it, that despite an older age group, which is very common in our country, you can get very, very excellent primary and secondary results. And recurrence can be definitely treated by a simple tenotomy and recasting. So hopefully we will need lesser and lesser extensive surgery for syndromic club feet if we just modify our technique as I showed you for the atypical club feet. So with this, I'll really quickly end and hand over to our next speaker, who is Viraj Ingade from Nagpur. And I'll request him to start sharing his screen. Viraj, can you come on and share the screen, please? Ashok, have we lost Viraj or is he still on?
No, he's here.
Viraj, just unmute yourself.
Viraj sir, unmute yourself.
Yeah.
And please share your screen. So Viraj is from Nagpur and he deals with a lot of these people who want a one-stop shop, like a kal ho na ho almost. So Viraj, I'll request you to talk more about your osteotomies rather than the tib and transfer, because I think 2 previous speakers have already covered it.
Yeah.
Over to you, Viraj.
We can't see your screen yet.
You can't see the screen?
No. Below our videos, click on the share screen tab and then share your PPT. Sir.
Yeah, share screen.
Yeah, we can see now.
Yeah. Can
Open your PowerPoint. Yeah, we can see.
Yeah.
Go ahead.
Yeah. Thanks, Ashok. Thank you, Alaric and Rujita, Sandeep and Taral. Rujita and Alaric and Atul has given a nice brief overview of the Ponceti technique and even management of the relapses, right? I was given a task to speak about the management for the walking age children, right? So there are a few, I will just go some case by case. So this is a first case. She's a 3-year girl. She's walking with this deformity. She has not been treated in past, right? So this is the way she's walking. So there's almost demiglio, you can say a grade 3 or 4 deformity. This is a neglected club foot. So when she presented, I think it was 2004 or 2005 when we was very much on a gear of Ponceti. So, and there was only few articles at that time available. I think only Monica and one more article from Nigeria. There were 2 articles only that they tried to treat these children, walking children, neglected club foot with the Ponceti. So I thought just we'll go ahead with the Ponceti technique and started casting her. So this was after a few of the corrective casts. This was first, and this is I think almost 5th plaster. and then this was followed by the tenotomy, and then this was a correction. Okay, so reasonably good amount of correction which is there. So I was convinced that okay, these children they can be managed very well with the Ponceti, and now there are so many articles even from Wadia also, from our colleagues, many of colleagues from Mumbai as well as from Delhi, they have published the articles that Ponceti works even for the neglected clubfoot deformity. And yes, it's true that when the child is in a walking age and with say grade 1 or 2 deformity by Demaglio, or you can say by Pirani's flexible type of club fit, even though it is neglected, they can still respond to the Ponceti well. But as you know that as Sandeep keeps on speaking in his lectures that a picture bhi baki hai dost. So in it, what matters in the club foot is you have to observe these children till skeletal maturity, right? So this was the time we kept her in a good sprintage protocol, and then she was having regular follow-up also. But after 2 years now down the line, the recurrence started. So there is recurrence of the deformity. It has just started, and there is as well as if you see there is torsion in the tibia also. Subsequently, the deformities they increased, right? And this was a time then I had to think over that again. Now the parents were saying, no, doctor, we want now definitive treatment. So we decided first to go for the left foot osteotomy, and this was even the external osteotomy of the tibia as a fibula and osteotomy for the foot. I will speak on later. And subsequently, you can see the difference between the 2 feet, the left and right one. So then subsequently, the right foot also needed the osteotomy. And then we kept her follow-up. In the follow-up, this is a 3-year follow-up she had. And subsequently, we kept her 6-monthly and 1-yearly follow-up. And then this is 5-year follow-up. And this is 12-year follow-up of this girl. So she is almost now skeletally mature. And you can see the girl, when she presented with this, we tried first with Ponceti. We could get good correction, but then deformities recurred. And then finally, she required the osteotomy. And this is her current. She don't have any kind of pain, not any kind of arthritic changes. So we keep our most of the children who have undergone, this is the hopping what she's doing, and that is there. So the idea of behind presenting this case is that it's not like that every case is going to respond to particular treatment. So clubfoot is such a condition where you need to have a case-based approach where you have to decide what is going to work. Now come with the second child. This is now again the 3-year. Now this is the male child. It was a 3-year female, and he was treated with a Ponceti, and then he had recurrence elsewhere, and then he came with this. We tried with cast, initial cast we gave, but still the deformity rigid. It was not a dynamic supination, but it is a varus and adduction of the foot which was not getting corrected. And this is a closer look. So naturally, these type of children, they may require osteotomy. So we did the osteotomy of the cuboid decancellation, and then he did well. You can do, and then additionally we had to do the tenotomy also for the tendo HLS. Additionally, as Alaric has mentioned, you can do the tibial eccentric transfer also. But the idea of showing this case is that there is definitely a role of osteotomy. You can either do the simple decancellation of the cuboid, or you may just you may go ahead and you can do the just distal calcaneal. You can just osteotomize like Lisch-Blau procedure, or you may take out some portion of the cuboid as well as the calcaneum, and then we can fuse it, right? That is there. Now consider the third case. Now this is a 5-year child who is walking with this. It is a neglected clubfoot again from a very poor background. So what is special about the child is, now this is a grade 3, grade 4 Demaglio deformity. It is not a flexible variety. So the special about this child is it comes from very low socioeconomic status. He has very limited resources. He is not ready to stay at my place or at Nagpur for a long duration because they have their farming and other issues for the parents, and they want a single stage treatment. So what to do with this type of children with grade 3 or grade 4 demiglio deformities and a neglected one? What to offer for that? And in Nagpur, and particularly most of those practitioners who are practicing in small cities or like taluka places, they are not, I mean, uncommon to get cases like this, or the relapse cases where the tertiary care centers do get where 2 or 3 times the soft tissue release and other surgeries has failed. So what do I offer for these kind of cases? So we came out with a novel idea where at one stop we go ahead do the plantar fasciotomy, that is to correct the cavus, and then we do the percutaneous tendoachelis tenotomy to correct the equinescent varus, and we do the dorsal closing wedge osteotomy at the same sitting, right? So this is the pictorial presentation where we cut the tendoachelis, we do the plantar fasciotomy as well, and this is in addition to that we take out a dorsal close wedge where we take elliptical incision, we separate out the muscle, and then we take out the dorsal edge which starts from right from cuboid, then all the 3 cuneiform. If it required, we sometimes we involve the navicular also, and sometimes the basis of the metatarsal as well. But mostly it's sufficient if we take out the cuboid and 3 cuneiform, and then we close the wedge and then stabilize the forefoot to the hindfoot with the help of the wires. This is how the forefoot is stabilized to the hindfoot with the help of the wires, 3K wires, and then we just close the wound and just put the drain on the third post-operative. We just from the window we pull out the drain and just send the patient home, and then directly comes back at 6 weeks where we pull out the wires, and this is the amount of correction what we have. So just the wires were pulled out and see the amount of correction which is there. We extensively worked out on this surgical procedure where we did the morphological studies, the functional evaluation, and radiological evaluation given by the International Clubfoot Study Group and the Bensal and Demiglio et al. So, and we found that the technique is not only effective for the neglected variety, but it is as well as equally effective for the relapsed variety of the clubfoot. So this, the child which has shown you, the child who has from a very poor background and they want they one go and one stage treatment. So this is how the correction what we gave from the dorsal closing osteotomy. So this is a plantigrade foot with what he is walking, and we keep these all children under long-term follow-up. This is a 5-year follow-up of the same child. What Alaric was talking about, the squatting, you know, the squatting is very important position which is required by the children. So in the villages particularly, right, and actually everywhere, the squatting is one of the very important bit, and it is possible because we are not disturbing the subtalar joint. Rather, we are preserving the subtalar joint in the dorsal closing edge osteotomy, and that is why the flexibility of the tissue is also very well maintained, and the child can do the hopping and other functions. This is a squatting, and this is a dorsiflexion of the same child. So you can see that due to preservation of the subtalar joint, there is good range of mobility at the foot, and it is absolutely a penless foot with good mobility. This is an example of the recurrent deformity. Now a 9-year child who has undergone 3 times the surgeries. You can see the scars of the previous surgery, the 3 surgeries, including the posterior medial release, including the Ilesaro and the Ponceti, which were done at some other centers, and this is the way he presented. Now again, this time, this kind of fit where the parents are already fed up with our treatment, they want at a straight go type of treatment, where again this the closed edge osteotomy worked very well, and this is a 4-year follow-up of this child. After doing the osteotomy, we did the dorsal closing osteotomy, and this is a 10-year follow-up. Already he has achieved the skeletal maturity, and see, he's walking very well, he's running, and he's doing all functions, including the hopping also. And this is the way correction what way. So the dorsal closing osteotomy work even for the recurrent variety of clubfoot where the previous surgeries has failed. Another example where this 8-year girl, she had a neglected type of deformity where we did the osteotomy, and this is the function. My idea of focusing here is basically the amount of function what they have. So that is very important. So so the amount of function what they have is very good, and I'm sorry. Yeah. This screen has gone, Ashok. Hello.
Yes, sir. Your PowerPoint is restarting.
Restarting? Okay. I don't know why it is. Just a moment. Yeah. Just really. I have to close this program and restart again.
No, just check on the recent today on the left side, management of walking.
Yeah.
And you can click on it and it will start.
Okay.
Yeah.
Shall I
Go to PowerPoint mode and start.
So.
We can actually see your screen, Viraj. I think just make it full slide.
This is. Shall I click on this?
No, just go to
Close
the
that.
PowerPoint mode directly.
Close that. Yeah. Yeah, now full screen.
Not that one.
So sorry. So thanks God we have a technical expert like Ashok with us, and then
Viraj, but you need to wind up. There's one more talk after you.
Yeah. I will just wind up within 2 minutes. Yeah.
Yes, sir. That one.
Yeah. I'll just go so that to save the time. Just one case I think I will show, and then I think. Sorry for the interruption. Yeah. So the advantages of this technique is basically it's a single stage procedure, and there are no much wound problems on the medial aspect because we are closing it on the lateral aspect, and so there are very less chance of neurovascular damage. And there are few disadvantages. People have spoken that there can, yes, I do agree that there could be a shortening of foot, maybe 1 centimeter like that. But even if you see the original Ponceti's his own series, and they have compared that there could be shortening of even up to 2 centimeter that they have shown even the when they are managed with simply with the Ponceti technique. There's special consideration I would like to mention in this type of particularly those syndromic feet we are presenting out very late stage. What we do, we extend the same incision which we take for the tenotomy, and from the same incision we do the release of the posterior ankle capsule, and sometimes in the subtalar release also we do from the same incision. That is required for some cases like orthopaedic clubfoot. Like this was a child. He has presented from Nigeria, and he has 5 surgeries has already failed, and it was absolutely like a stone, patthar ke sanam jaisa. It was hulling and doing absolutely no movement. So in these type of fit, definitely you have to do the releases, and the dorsal wedge what you are going to do, if they require a little wider dorsal wedge where you may have to include the navicular and sometimes the base of the metatarsus, and this is the correction what we got for the 1 feet. Then he was happy with the deformity correction. He came for the second surgery for the another foot next year, and this is the correction what we got. We extended this our techniques indication to the neurogenic foot. And neurogenic foot are not so simple because even if you do the best soft tissue balances, sometimes they recur. Many times they have this osteomyelitis and then ulcers, and so we have to the advantage of is that you can take out the ulcer from the same incision, and the bad bone we can take out. And this is a follow-up, long-term follow-up. This is 7 and almost 10 years follow-up of these cases. This is a 10-year follow-up of the we have published this paper also. So this technique works even for the neurogenic foot. And what I will mention about the triple orthodosis, yes, when nothing works and if you are getting a very painful stiff foot with a poor function, there is definitely a role of triple orthodosis. In summarize, you can't see that only one technique is going to work for the club foot. For the fit, what we are seeing, the Indian surgeons, what we are seeing, the walking age children, the flexible deformity, you can still try with the Ponceti extended indications. You can sometimes go for the, if the grade 2 deformity, you can give even for the Evans or Fishbaugh type procedures. And if the patient want a one-time treatment, the single go treatment for the grade 3, grade 4 deformity, above 5 years of the age group children, you can definitely go for the dorsal wedge osteotomy, and we have very, very long-term follow-up of these children. It suits to our all patients from the developing countries, and it works very well. And of course, for very painful foot, you don't have any other option. You have to go for the orthodosis. Thank you for all for your attention, and sorry for the disturbance what we had.
So thanks, Viraj, for going on despite difficulties, and we move on next to our last but not the least champion from Oxford, Dr. Ishani Shah, who's going to take us to the realm of fixators, because that is something which is trained in extensively in India as well as abroad. Over to you, Ishani. Please start sharing your screen.
Thank you, ma'am. So, ma'am, I've moved on to Manchester now. So, talking from Manchester. So, when you have exhausted all your options, when a clubfoot, which has been treated but did not respond to treatment and is resistant, when the deformity comes back, or in a child which has never had treatment, what do you do? Gradual correction with a frame is a useful skill set to have in this situation. I have borrowed the images for this talk from my bosses in these 3 centers where I've trained, from Ruchita Madam at Wadia, from Mr. Nayagam at Liverpool, and Mr. Fernandez at Sheffield. When do you do a frame? It is definitely not the first line of treatment. When a child has had previous surgeries and there is scarring in the foot, any other further open surgery is going to scar it more, and that is when you think of a fixator. In older children who have rigid deformities, again, fixator is your friend. In clubfoot, the deformity is 4-dimensional. There is a 3-dimensional deformity in the bone and soft tissues, and this deformity worsens with time. In a child who is weight-bearing on a deformed foot, the osseous anatomy is ossifying while the forces are transmitting through the malaligned joints, and this is causing these abnormal forces to deform the bones further. In this situation, only an external fixator to stretch the soft tissues is not going to be enough, and you might need a combination of an osteotomy with an external fixator. Paver's score can be used as a guide to assess and to help you what to do. It is a clinical score which assesses 5 parameters in the foot. These 5 parameters are scored based on the angle of deformity into 1, 2, 3. This factor is then multiplied depending on the age of the child, and the final score tells you whether you should cast the child or go ahead for some other form of treatment. With an external fixator, you are doing more than just stretching. You are inducing growth based on the principles of distraction, histogenesis. It's not an acute correction, so there's no imminent danger to the nerves and vessels while you're doing this gradual stretch, as long as you put in your wires through the safe zones. It gives you the advantage of making adjustments while doing the treatment and post-operatively to keep monitoring your correction. And you can have a more precise correction while doing it. In an osteotomy, in a closed wedge, the foot size will decrease, while in a fixator, you have the benefit of increasing the size of the foot. You can use the different principles of osteotomy in correction with a fixator if your cora and your angle of correction are at different points. The fixator is a stable construct which the child can weight bear in, and this helps reduce or prevent the osteopenia that can go with the long-term treatment in the child. Based on what you have in your toolbox and your skill set, there are 3 different types of fixators that can be used in clubfoot: a just fixator, a circular Elizaro fixator, or a TSF or a hexapod. These can be quite tricky and challenging, all 3 of them, and don't hesitate to phone a friend in these situations. The principle of Elizaro is tension stress effect, where a regulated controlled form of stress to the tissues causes them to be metabolically active and proliferate. This happens at the level of the connective tissue and the muscle and the bones. The frame can be an unconstrained structure or a constrained structure. When you do not use a hinge and you let the bony anatomy guide you, that is called as an unconstrained structure. And a constrained one is where you use the hinges to guide you to the direction of control and the position of correction. Any fixator will have 3 phases. You have the correction phase where you will do the turns, and that will correct the deformity. You have a static or a holding phase where you want the tissues to lose their memory and stay in that position. And then you have a maintenance phase, as has been explained by all our speakers, that the tissues do want to still go back. So you have to maintain them in a splint during daytime and nighttime. Any fixator will have a bony hold in 3 segments: in your tibia, in your hind foot, in the calcaneum, and in your forefoot. And these segments will be connected to each other by your distracting rods or the motors. The tibial construct to the hind foot to the forefoot, and the forefoot to the tibia. JESS is an unconstrained system which uses the soft tissues as a hinge to turn around and correct the foot. It relies on the normal anatomy of the child. So the earlier the deformity is to be treated by a fixator, JESS would be the preference in a younger child. These wires are not tensioned, they are only pre-stressed, meaning that they can be used in softer porotic bones, but the construct is not stable enough to weight bear. These frames are easier to apply since you don't have to think where to put the external hinge, but these frames often need to go back to theater every few weeks to adjust your rods while the correction is happening. This is an example from Vadia, a syndromic child, 3-year-old neglected clubfoot who had a JESS treatment, and on the right is the correction post-removal of the frame. In a circular fixator, as I said, you can use it only for soft tissue distraction with maybe a percutaneous soft tissue release or alongside an osteotomy. Younger the child, the better result will be with only soft tissue. These feet have some mobility and you can use that to correct your deformity. While in older children with arthritis, with deformed bones who are older than 8 years of age, rigid feet are more likely to need an osteotomy along with the fixator. The frame looks quite complex, but if you break it down, the 3 segments, as I said before, there are 7 motors plus 1 motor that goes at the end of the correction. There are hinges which need to go alongside the joints, which will guide your correction. This frame needs to be distracted for the first 5 days so that the talus does not impinge or crush against the ankle. All the motors will need a differential distraction based on the severity of deformity, and it uses the principle of Ponceti, which is a simultaneous correction of all the deformities. The hinges are the crucial part of the circular fixator. The tibial frame connects to the heel frame with a hinge at the ankle, which forms the bimalleolar axis at the level of both malleoli. If you can see this hinge, the posterior motor, this is the crucial hinge which needs to sit at the level of the subtalar axis. Now this axis goes in a normal foot from the posterolateral to the anteromedial. So this hinge should coincide to that level of the joint. A differential correction will correct the varus and the equinus in the hind foot with these hinges. The hind foot now connects to the forefoot, and these are motors dropped down plantarwards on the medial and lateral side, and again a differential distraction to correct your cavus and adduction. The forefoot frame connects to the tibial frame, again with 2 rods with a T construct on the distal tibial ring. And these again with a differential distraction correct your forefoot equinus, the cavus, and the supination. The last and the most important motor, the 8th motor for derotation, is attached to this T extension, and the hinge for that sits at your talar head, and the motor is medial, which turns the forefoot around to reduce the alignment and externally rotates the calcaneum. You can use different colored markers for your distraction motors to guide the patients as to what they need to do when for which rod. Toe contractures can be prevented by using K-wires or toe slings in these patients through the treatment. And as described in the previous talks, tibialis anterior is often stronger in these children than the peronei. So a transfer, tibialis anterior transfer can be planned at the end of the correction. This is a case from Liverpool, which was a 7-year-old child with a circular fixator for correction and the cast in overcorrection at the end of the treatment. Do remember to hold the frame as well in slight overcorrection in the static phase. On the left is a case from Sheffield, 7 years follow-up. Again, a child who had previous soft tissue releases and relapsed, and the frame with a post-correction 7 years follow-up. On the right is a bilateral symmetric deformity, the right side being corrected and the left side now going for treatment with a circular fixator. The osteotomies are a separate talk in itself, along with fixators, and there are complex osteotomies, a U-shaped osteotomy of the talus, a V-shaped osteotomy where there is a deformity in the hindfoot and the midfoot, and along with this osteotomy, then placing the appropriate hinges corrects the deformity gradually. The Sinai team, the Sinai group, has described a technique called as Ponceti, which uses Ponceti and the talar spatial frame for correction. It comprises of 2 rings, 6 struts, and they have said that it controls the rotation better. There are 2 types of frames that they have described. Type 1 is for a hindfoot deformity with a mild component of forefoot deformity, and a type 2 frame is a severe foot with both hindfoot and forefoot deformity. They have staged the correction into 2 stages. They advise to cast the foot for correcting the forefoot and then go on to TSF. In the type 1 frame, so after correcting the forefoot, the stage 1 corrects everything other than the hindfoot. And in stage 2, they modify the frame and then go on to correct the hindfoot. What stage 1 comprises of is an epiphyseal wire, which connects to the tibial ring to prevent separation at this physis, and an olive in the talus, which again connects to the tibial ring to prevent any motion, any correction at the ankle joint. And all your correction in stage 1 will happen at the subtalar joint. So you can see how the oblique frame becomes straight. And once that is done, the talar wire is disconnected from the tibial ring and connected to the foot ring. And then the equinus is corrected. As you can see, the angle is correcting here. And once that is done, they overcorrect the deformity by about 15 to 20 degrees. The type 2 frame is same as type 1, with the only difference that at the end of all of this correction, the forefoot ring is cut at 2 places, medially and laterally, and an Elizaro extension is applied. And then the forefoot cavus and adduction is corrected as Elizaro on this frame. This is an example from their paper where they have shown a pre-op and a post-op correction with Ponceti technique. As with any frame, there are complications, frame associated of pin site infection, pins losing out, cutting through, contractures in joints above and below, and infection in the bone. Specific to the clubfoot team, you have to watch for a talar subluxation. While you're doing the distractions, watch for fascial separation. This can eventually lead to growth arrest, so you need to monitor the child for that. And toe contractures, which can be prevented by K-wires or toe slings. A lot of papers in literature, most of them have shown good results with frames. One paper from 2006, which has suggested that results were poor with the frame correction. TSF is a fairly recent method, and the literature describes only the technique and just one paper with short-term immediate results, which have been good. We are currently doing Ponceti in Manchester, and hopefully we'll have something a few years down the line. Fixators are tricky. Tread carefully when you go ahead with them. They can go either ways, so be cautious and don't hesitate to phone a friend if you are struggling.
Thank you, Ishani, for a very well-rounded talk. And I'd now request all the participants to switch on their videos, and if Alaric can please moderate the question answers, because we've had a few interested responses from the audience. Over to you, Alaric.
Yeah, thank you, everyone. I think we have had a great session out here. And a few questions which have come up. So there's one which has been asked about the what happens in COVID times. And that's a very pertinent point, because we have a pandemic which is ongoing, cases rising, and we're going to have this going on for another few months more. Can everyone see my screen? Ruchita, can you see that?
Yes.
Yes.
Okay, so what we have devised, we all know that during the lockdown phase, many clinics have shut down. And now that the lockdown has lifted, we have all those cases coming back. So we have a few suggestions. Once the lockdown has eased, how do we deal with this backlog of cases? So I think it's important that we don't get overwhelmed with the number of cases that come back in, especially those of us working in trust hospitals or public hospitals, where we see a large number of clubfoot patients coming to our clinics. So one mechanism is to increase the number of clubfoot days that you're seeing patients. If you're doing it once a week, maybe do it twice a week, so that you can spread the patients out over the week. The second is to prioritize care so that you don't bring in all the children together. We know that 3 months of lockdown has caused a backlog of cases. So bring in those children who have had an interruption to their casting phase. They are the first priority. The bracing phase, children can afford to wait. So we'll not call them back yet. We'll call the children who have had the casting phase interrupted, get them sorted out, finish off with their tenotomies, get the foot fully corrected, and send them off with the brace. Then, of course, call the children who have not been registered during the COVID lockdown. All the new patients who didn't get treatment should be called in next. The good thing with the Ponceti method, as we have already shown in our publications, that even in the older child, the Ponceti method can work quite well. So therefore, you should not be worried if there's a 3-month delay in treating these children. You can reassure the parents that even at the older age, we can treat them successfully with the Ponceti method. One technique that we have used at Wadia Hospital, which will be published soon in the International Orthopaedic Journal of CCOT, is what we call barrier casting. And I'll show you a few of these slides. It's a very simple Jugadu technique that's very typical of us in India. So what we know is that the main spread of COVID is because of aerosol transmission and contact droplet infection. So the main thing is to isolate the parents and the child from the treating physician. So what we've done is use a simple plastic drape like this. You can hike it up on 2 IV stands. Make a small hole in the 2 small holes to bring the foot of the child out. So that what happens is that the parent, a single parent, caregiver with the child is on that side of the drape, and you are on this side with the child's feet out through those little holes. So therefore, that's an effective barrier for aerosol transmission or droplet infection. That's a side view showing how you have isolated the parent and the child from the doctor. And then, of course, with the standard precautions that are required, you don't need specialized masks. Of course, a simple mask would do. But if you have an N95, that's also very nice. You can have a face shield like this, wear non-sterile gowns and gloves. And you can see that very effectively, you can create a barrier between the parent and the child on one side of the drape and you on the other side. So this is a technique that we found to be quite useful. And any of you who is interested in taking this up, I think this is a very practical approach to how to take care of yourself during the COVID pandemic. Thank you.
And the other question about a midfoot break and the recurrent Ponceti error, I think Samir should answer that.
Yes, so there was a question about how do we deal with a midfoot break, and when do we know that we're developing a midfoot break, and how should we go about dealing with that? And once it has been corrected, how do we brace it? So Samir, do you want to answer that?
Repeat the question, I think, for him.
You want me to repeat the question through the chats?
No, I've already said the question. You give us the answer.
So important thing is to score the foot before you start the treatment, and don't touch the heel when you're using the don't touch the calcaneum when you're correcting the foot. The pressure should be applied over the head of the talus. And once you feel that the midfoot score is 0, a good technique could be do a lateral X-ray and measure the lateral tibiocalcaneal angle. And if the tibiocalcaneal angle is more than 85 degrees, it is said 81 degrees, it is said that the soft tissues are also tight in that child. So you should always do a tenotomy in those children and avoid manipulating the foot back, dorsiflexing the foot. So a percute tenotomy will be very helpful. And then in some children, you can also brace them in less than 70 degrees. So you can brace them in around 30 to 40 degrees.
Great. Thanks for that, Samir. There's one question for Viraj quickly. The question is that for your technique, which relapses need tibial and fibular osteotomies alone?
Yeah, tibial osteotomy is very rarely required. Very like the child which I have shown you, she had a very severe intorsion in the tibia, right? So the intorsion in the tibia itself, along with the grade 4 deformity. So only in so many years, only 2 children they required a tibial external rotation osteotomy. Otherwise, most of the children they don't have the inherent intorsion in the tibia, so they do well with a simple midfoot osteotomy.
Great. There's another question which I think I'll address it to Rujita because she covered the atypical clubfoot. when you have a plantaris deformity in an atypical foot, you have already shown us where you apply the force, but the question is, where is the fulcrum?
So I don't really think that there is a fulcrum in a plantaris. What has happened is, if you really observe the foot, it's like as if the forefoot has fallen down, dropped down between the midfoot and the forefoot. So what you're doing in this technique is you're really merely elevating it and bringing it back. You're not really rotating it or taking it into another axis. So you're simply re-elevating what has dropped down. And if you really want to consider it as a watershed or a point around which it comes, then I think it's the entire midfoot, forefoot junction where this occurs. So where the deformity occurs, you re-elevate it from that.
Yeah, so I would agree with Rujita on that. The main thing here is not to abduct the foot because it's already hyper abducted. You have got a midfoot break when you have an atypical foot as well. So the important thing is to forego that attempt to abduct the foot at the with pressure over the talus. The atypical maneuver is applying pressure over the metatarsal heads, the first and the fifth equally, so that you raise the entire forefoot up against the midfoot. And that's where your maneuver should be. Are there any questions? We have another couple of minutes more to go before I'll lead Dr. Ajit Shinde to wind up the discussion. If there are any other questions, Ashok or Sandeep?
No, I had put a question. Sometimes after Ponceti, Alric, we do find that we get a toe deformity, metatarsophalangeal adductors. Even though the foot looks nice with Pirani scoring, they are toeing in because the metatarsophalangeal adductus is there.
Yeah, that's a good observation. And I think most of the time this is supple. You have what we call so this is what we call a medially seeking.
Yeah, it is supple, but it's quite disturbing to the parents. Do you have a strategy for that?
Sure. So this is what we call a medially seeking big toe. It's not really a forefoot adduction because the rest of the forefoot looks fairly fine. But the first toe, the big toe, tends to seek inward, especially when the child walks. Some of it can be because of a dynamic abductor hallucis. And what we have found in these cases is that sometimes taping works well. So we send them off to the therapist who does kinesio taping, and that helps to correct the medially seeking toe. In occasional cases where we have had them to really persist and look really bad, and the parents are quite upset about it, sometimes it interferes with wearing chappals as well because they can't grip the chappal between their two toes. Then in very rare cases, we actually do a tenotomy of the abductor hallucis, and that helps to correct that medially seeking big toe. Plasters, I don't think have a role to play because the deformity is so distal and there's such a short lever arm to work on that I've never been successful using plaster. So they are the two techniques we use, either taping for the very mild deformities or doing a abductor hallucis release through a very small incision for the severe ones.
Okay.
And
There's
can I
also
add to
one
that,
more
Alric?
observation I have. Alric?
Yeah.
Can I just add to the previous third strategy, which we can ask the parents to do is simply use reverse shoes, which we used to do a lot in Vadia in the good old days. Especially because these children are already walking and they don't want to use braces in the daytime. So we intentionally put the right foot shoe in the left and the left foot shoe in the right, so that a straight border can just keep
straight
holding
medial
the
border.
Yeah, go ahead. You had something to say.
Also, my observation is that sometimes the parents complain about the overlapping second toe. Now the question is, it might be there from beginning, but it is attributed to the cast. So I feel for those who begin with Ponceti casting, two things need to be brought to notice of the parents. One is peroneal palsy if it is pre-existing. Second is a atrophic calf when it is unilateral. And third is an overlapping second toe which is there from beginning. Otherwise, all these three things are blamed on cast. Do you agree?
That's a good observation again. And I would also say that sometimes this overlapping toes can be iatrogenically caused. As you bring the foot out into abduction, if you crowd the front of the cast, and that's what Ponceti was very particular about, that you have to flatten the cast so that it looks like an oval and not round. Because when you finish a cast which is round, you're going to overlap all the toes together and crowd the toes. So he was very particular during the casting that you must flatten the front of the cast so that you have a good metatarsal rhythm and all the toes are separated out. So I've seen occasionally it's iatrogenic caused by us. The good thing is that it tends to go away. It's very supple. It doesn't cause much problems. Here again, I found that taping has a role to play. And the good thing is that most of our brace designs are open-toed, and that's a good thing. I don't think you should put them in a closed shoe then. Encourage the parents to use the open-toe sandals in the daytime and open-toed braces in the night. So that helps to ease that toe problem out.
Yeah.
Alaric,
Yeah.
can I have a word? Yeah, good observation, Sandeep, as you told that, but I differ from Alaric in this that many of the children, Alaric, they have the inherent overlapping of the second toe, which when the foot is so much inwardly turned, so it is not visible. Once you abduct the foot, then it start, appearing. So that is there. So at the time of first counseling itself, we tell the patient that this can be there. You should be mentally prepared for that. And as Samir has mentioned, and even Sandeep has mentioned, in calf hypertrophy can be there. We also mentioned about the size of the foot. So foot size also can be small in particular unilateral cases. That also we counsel in the first when the child comes for the treatment.
Sure. All valid points. I agree with that. Any other questions or any other comments from Sandeep, Taral, Dr. Shinde?
I am having one question as well as comment prior to giving closing remark.
Yes, go ahead, sir.
Dr. Viraj
Sir.
and Ishani Shah, madam.
Yes, sir.
Congratulations for nice presentation. I am asking for Shindade as well as madam, whether you are having any experience of dorsal wedge, osteotomy and differential distraction with Elizarov for correction of the deformity where there is no problem of shortening and you can construct the foot. In late presenters, delayed, neglected, relapse foot, more than 8, 10, 12 years of old.
Sir, in my opinion, I think the neglected foot is a different ballgame. And if some surgeon is like, there are many senior people who are expert in Elizaro, they have huge experience of Elizaro, and if they can manage with them, and if they can manage with Elizaro, I mean it's fine. So if the child is ready for the compliance, for the follow-ups, and the parents are ready for the all the instructions what you are giving, and they are educated enough to understand the method of treatment you are going to offer, Eliezer also can it can work very well. I mean, for the in the good surgeon's hand and the senior expert surgeon like you, it works very well. I don't deny the fact. I am talking about those children where they have come from very, I mean, uneducated background or the poor background, were very difficult to get the, follow like the frames like Ishani has shown us. In our country, it will be difficult to get those kind of frames. That is the problem we start. So I mean, so managing these that kind of data where when one kind of once go treatment is expected from the parent, the dorsal osteotomy works very well. That is there. But yes, even like PMR, people say that there is no role of PMR, but for the orthopaedic recurrent clubfoot, there is definitely a role of PMR. So I think every surgery has some role. I mean, the clubfoot is such a condition where every the technique has a role, and it is a matter of surgeon expert and the expectation of the parent and the education level of the parent. That is what matter.
Rujita, if you allow me, Dr. Shinde, you are absolutely right. In difficult cases, one will have to use everything together. Soft tissue releases, osteotomies, and external fixator, and use a slow distraction. So there are cases where you have to use everything. So Ishani, you will have to use everything what you've learned from Vadia and UK, all mixed together, make a khichdi out of that and enjoy the taste. Yeah.
As I said before, that fixator should not be the first line of treatment. And we have enough literature showing that no matter what the age, Ponceti can reduce the deformity, if not correct it. So always try that as your first line of management and then further on whatever is needed.
Ishani, that Poncet Taylor that you showed, I remember the trials of Jess Fixator were done in Sion Hospital, and Joshi sir, BBJ and Joy used to do those cases. And the old man Joshi sir used to always say, "Arey wo bhai frame ko over scare karo." So what he wanted to say is over square. So you have to disconnect the distractors and actually make it over square. So that is probably what is being done using different rings and fixators and changing the rods. ultimately what we do in JS is we remove the distractor and put your thumb on the talus and do Ponceti. So it's like instrumented distraction, which Joy always said, this is instrumented distraction. Ultimately, we are doing Ponceti. That insight he got after meeting Pirani in 2004, 2005. But in 92, 93, it was Joshi sir who said, "अरे भाई वो 3 squares को over square कर दो, opposite direction."
Everything initiates in India, sir.
Great. So I think if we have done with all the discussion, thank you very much to MOA for inviting us to run this very stimulating webinar. And over to you, Dr. Shinde, sir.
In future, I will show the correction with Elizarov and dorsal base osteotomy if chance comes. It was a great experience. All faculties done their job sincerely and very nice. I'm sure all the viewers have definitely upgraded their knowledge, including myself, about Clubfoot. Thank you, everyone. I hope we will continue this teaching program for next Sunday also. So I am asking now Taral and Sandeep, what will be our program on next Sunday?
Taral, you are mute. Taral, you are mute.
We will request a little break from pediatric topics. We have done it for last 5 weeks now. And we need to all prepare for upcoming IFIX conference. It's going to be 8 sessions over a whole month, and all of us are preparing very hard. So we would just request you that give a break to viewers as well as us from pediatric for some time, and we'll come back. We'll come back again in November.
Okay. So we will switch up to the another topic, and then again we will meet for pediatric.
So from MOA, please ask everybody to attend IFIX.
Already I have circulated your...
Yes, sir. Thank you for that. Thank you, sir.
Ashok, shall we stop streaming?